MOA of SSRI like citalopram, escitalopram, fluoxetine, fluvoxamine, paroxetine, sertraline. It immediately blocked the SERT at the presynaptic axon terminal, increasing levels of 5-HT in the synaptic cleft. The increase in concentration of serotonin in the synaptic cleft enables serotonin to stimulate the postsynaptic receptors for longer 5-HT1 autoreceptors downregulate on the 5-HT neurons. After the number of 5-HT1 receptors is reduced, 5-HT is disinhibited to release more serotonin in the synaptic space. This is followed by slow adaptive changes induced by chronic exposure to this medication. Serotonin syndrome signs and symptoms: tremor, confusion, agitation, hyperthermia, sweating, diarrhea. True or false? Most TCA are long-acting. This is because many of them have active metabolites. True. I check blood pressure before venlafaxine and disvenlafaxine. Venlafaxine and disvenlafaxine can commonly cause increased blood pressure. MAO. I like phenelzine, tranylcypromine foods to avoid. Food with high levels of tyramine like aged and fermented foods. Soybean extracts. Moclobemide does not interact with those foods. Which TCA is most likely to cause sedation? Doxepin. Fluoxetine, longest half-life. Fluoxetine has an active metabolite that gives it the longest half-life of the SSRI, up to 16 days versus 24 hours for other SSRI1 class in use in Australia. OA. It inhibits reuptake of NE at noradrenergic neurons, potentiating transmitter action. The antidepressant action is not seen until a few weeks later. It also weakly inhibits reuptake of serotonin. Adverse effect for TCA like amitriptyline, dimipramine, dosulepin, doxepin, imipramine, nortriptyline, 5-HT2 receptors, will ease depressive symptoms, muscarinic receptors, dry mouth, blurred vision, constipation, and urinary retention. Histamine receptors, causes sedation. Alpha-1 adrenoceptors, postural hypotension, sodium channels, cardiac arrhythmias due to blocking sodium channels in the heart. MOA. Agomelatine. Agomelatine is a melatonin receptor agonist and 5-HT2C receptor antagonist. Agomelatine resynchronizes the disturbed sleep and wake cycle in depressed patients by delaying the sleep phase rhythm via its MT1 and MT2 agonist action. It also increases the release of dopamine and NE in the frontal cortex via its 5-HT2C antagonist action. Thus, it may aid in reducing sleep disturbances often associated with depression. Adverse effects: SSRI nausea, vomiting and diarrhea, stimulation of postsynaptic 5-HT3 receptors, insomnia, and anxiety, stimulation of postsynaptic 5-HT2 receptors, sexual dysfunction, loss of libido, stimulation of postsynaptic 5-HT2 receptors, insomnia, for most SSRI. But citalopram or paroxetine cause drowsiness, liver function measured before agomelatine. There can be an increase in aminotransferases. Amitriptyline is more likely to cause drowsiness and escitalopram is more likely to cause insomnia. MOA of TCA, it blocked the uptake of amines, predominantly 5-HT and NE by nerve terminals, by competition for the binding site of the amine transporter SERT and NET. It blocked both SERT and NET, and nortriptyline has a greater effect on NE uptake. Most TCAs also block other receptors like 5-HT2 receptors, muscarinic receptors, histamine receptors, alpha-1 adrenoceptors, sodium channels. Match drug class: moclobemide. MAO. Imirtazapine, serotonin receptor antagonists, duloxetine. SNRINOT, a common adverse effect: mirtazapine among nausea, sedation, weakness, weight gain. Nausea is not same mechanism of action as mirtazapine. Myosin M.O. a serotonin receptor antagonists like mirtazapine, myosin. Vortioxetine, it blocks presynaptic alpha-2 adrenergic receptors on noradrenergic nerve terminals, which enhances the release of NE. It also blocks presynaptic alpha-2 somatodendritic receptors on serotonergic neurons, leading to increased serotonin release in the cortex. Furthermore, mirtazapine blocks H1 receptors accounting for its sedative effects, and 5-HT2, 5-HT2C, and 5-HT3 receptors, reducing adverse effects from these receptors like sexual dysfunction, and serotonin receptor antagonists differ to others. It does not act at the monoamine reuptake transporter protein sites, such as SERT and NET.